Welcome everyone to Modernizing Your Practice Through Medical Technology, an ASIPP webinar series. The title for tonight's program is EHR AI Scribing and AI Prescribing Webinar. I'm going to turn this over to Dr. Laxmaya Manjakanti, who will talk to us first.
You need to
I'll
stop
stop
sharing.
sharing. Here you go.
Okay, everyone, welcome to our first webinar, EHR and AI prescribing. We are going to explore how AI is transforming electronic health records and prescribing practices. So this is my disclaimer. I'm not getting paid anything on this or any other things. So let us not waste too much time on that. Now this is today's webinar, October 21st, EHR. And we also have another one on November 11th, December 9th, January 13th, February 10th, and March 10th. Then we will be coming up with a new schedule. So if you're interested in, please go ahead and reschedule yourself for the other ones. I'm just briefly going to state what is going to happen today. So we have three moderators, Amol Soin, Kiran Patel, and Ryan Badwani. First session is about 20 minutes about AI scribing featuring paybackhealth.com, and moderators are Playback Health team. They will be introducing in few seconds. And then we will have a 5-minute discussion, question, answer, and moderator discussion by Kiran Patel and Amol Soin. After that, we will have another 20 minutes AI prescribing featuring SureMed compliance, and their presenter and panelist will be SureMed compliance team. After that, we will have 5 minutes question answers and moderator discussion with Ryan Badwani and Amal Soin. After that, there will be closing remarks and next steps in MedTech series by moderators. So session 1 is the overview of AI scribing with Playback Health. This is going to show us automated documentation, reduced administrative burden, improved note accuracy, and real-time prescription transcription. These are all extremely important items. We'll find out more. In session 2, overview of AI prescribing with SureMed compliance. Here we are going to look into the compliance, enhanced prescribing compliance, reduced medication errors, streamlined prescription processing, and real-time insights. And meet our moderators, Dr. Amol Soin. Everybody knows him, have seen him on many, many occasions. Then we are going to introduce Kiran Patel today. She is new for ASIPP, but she is not new for interventional pain management field. She has been very well-known speaker, especially on dorsal root ganglion stimulation. Now, Dr. Ryan Badwani, we have seen him for the last couple of years or so. He is also very much involved in the ASIP. So that's it. Now we are going to start it. Kiran, are you going to start?
Yes, thank you so much. So, thank you so much for that introduction, Dr. Manchikade, and very excited to be part of this series about how we can really incorporate the best of medical technology into our practices, and very excited to be more involved with ASIPP. And I have the pleasure of introducing the really the founders of Playback Health and a dear friend of mine and colleague, Dr. David Langer, who is the chair of neurosurgery at Lenox Hill Hospital and the vice president of neurosurgery for the Western region. He's also a full professor at the Hofstra Northwell School of Medicine in both neurosurgery and radiology. He founded Playback Health. He's also well known for his role and the creative genius behind the Lenox Hill Netflix series. And so I'm very excited to welcome him and Greg Odlin as well, who helped found Playback Health. And with that, I'll turn it over to David.
Thanks, Karen. I'll just share my screen. I appreciate the opportunity to be here today. This is a unique audience to be talking to, and I think that my personal experience, both as the founder with Greg, has taught me one aspect about why AI is so important and why kind of utilizing what amounts to social media and social networking type technologies in the patient space is valuable. But certainly since ChatGPT came out, we've seen just a massive change in how AI is impacting our lives. And given what Playback's done for my life, just as a user, I mean, I haven't written a note in 2 years, and it's just revolutionized my ability to be a physician. So this is really neat to be able to talk about it both from a user perspective as well as a founder perspective. We've been at this for quite some time. Greg and I started this company in 2017, and we've gotten a ton of recognition because of originally for some of the core ideas about using video, audio, speech, and language at the point of care. And then more recently, we've morphed into an AI company by taking those conversations and turning them into notes. This is not transcription as we think of it. It's not taking what I said and putting that paper. It's basically taking the conversation and turning it into a structured note that can be designed for your own purposes. And that's what makes this so incredible, because it removes that administrative burden from the doctor and lets you be a patient again. These are our great team that we have. I have to point out this is not it's not a one-man show. We've got just fantastic people to work with to support the company and really built this thing. And Greg's just did an incredible job leaving Wall Street to take this thing over and driving this thing forward. And I couldn't be more grateful for the work and the passion that he brings to our company. And we just have a wonderful, wonderful group of people to work with. I sort of came up with this idea actually in 2008 of using video at the point of care. And I built this within Northwell, essentially recording conversation, recording my screen. And then when Greg and I have been talking about this over the years, we started the company and built this thing to really go the full enterprise. And the idea is, if I say something to somebody, why keep repeating it over and over? Patients don't remember what I told them, especially in pain. People are uncomfortable. Their concentration is short. They may be on narcotics. So they're struggling. And by giving them direct communication and their caregivers, recordable information, not only they can listen to themselves, but their caregivers can give them, and memorialize moments is really so valuable that it really changes not only how the patients get their information, but it gives them great confidence in what you've said. And this actually works great for medical legal reasons too. Patients are much more likely to not hear it or not remember it than what you've said. And this has really been, I've been unfortunately been sued a couple of times as a neurosurgeon. This has been a dramatic improvement, and what the lawyers are super happy about having this. So there's no downside in recording and giving patients what they need. In my department in neurosurgery, we saw a real big improvement in HCAP scores just using what we call Engage, which is the original product, which is basically audio, video, and texting directly mobile to mobile or mobile to web or web to web or web to mobile, both directions, to patients and their families. This content of a video or an audio could be easily shared mobile to mobile by patients to their families without some crazy passwording and all this kind of stuff. We turned into an ambient scribe company in 2023, and so that allowed us to generate notes in this generational AI to create conversations and go to notes. And that removed the administrative burden that I had in talking to patients. It's increased the number of patients I can see because I don't have to go worry about dictating and rewriting the note and having to do that all over again. And it's really accelerated the number of patients I can see and made me a better doctor because I'm just talking to the patient, listening to them, and I get this fantastic output that goes to the EMR. And then, of course, we have the security, SOC 2, and HIPAA compliance. That goes without saying. And the mobile apps are available both on the Apple App Store and on Google Play. So what engages the original, our original ideas. I send patients videos from the OR that tell them we're underway or that we're finished. From a pain perspective, it could be something as simple as sending them a picture of where your needle was or what pain scores are, or even maybe you want to record patients and how they react to your pain scales, and then have that recorded, or show people how you can record a phenotype of how they're walking or moving, and you can show that to them after you've treated them, a month later. Look how you looked a month ago. Look how great you look now. I do this all the time for NPH in particular. I actually do one pain procedure, Intracept, and I will show routinely where my needle went, show them, what my procedure was, and then I'll video them, in the office, and then what they look like afterwards. And they sometimes forget how much better they got. And this has worked really well in rehab and physical therapy, occupational therapy. I unfortunately was in an accident. I'll show you some pictures of that where I actually went to rehab and used playback, and my family could see exactly what I was doing. One video for multiple people. But you can do film reviews. You can, record your screen and say, here's your bad disc. You can show a foraminal stenosis. You can show, a spondylolisthesis. Why you need surgery. This is why I need surgery. This is not a great case for me. You can do after visit summaries, discharge instructions. And this asynchronous ability allows you to record one to many. So you can do this in the absence of your patient even being there. They can film review and send them something afterwards, and it's like they're looking over your shoulder. And there's powerful automation and clinical AI by taking those moments and turning them into notes. Pro is just the purely note-making component. So we have Engage, which is the video audio. The Note Playback Pro makes your note. And these notes, the AI improved the accuracy and complexity of these notes is just breathtakingly cool. I mean, I not only does it give you your note, but we can do billing and coding of the note and of the interaction. So you give the doctor the recommendation of what that code should be for the bill, as well as the ICD. And it can pull that out of the conversation. It's a remarkable improvement. And this is where all of healthcare is going. This is just the patient-facing piece. And then the provider-facing piece is this, note that we can create from the patient-facing interaction. So it captures the conversations, takes that audio, turns into text, then takes that text and generates generates a note. And you can have the transcription if you want it, but more importantly, you get this generational AI that creates a EHR ready note. And so we can actually train it, edit it, and send it in the document. And the notes are just, they're better notes than I've ever written myself, frankly. And I'm especially for proceduralists, this is great because we're really writing the notes for ourselves or for the insurer or for the lawyer that wants to come in and look at them. And very few people actually read my notes about my indication for surgery, other than my nurse, my resident. And so this just absolutely gives me the plan. I go back to them. Everything's at my fingertips on my mobile device with essentially no work at all other than a conversation. And this is some of my videos. These are all the different use cases for playback when you can create discharge instructions, screen recordings, audio notes. This is actually me doing physical therapy and rehab. I had a terrible spinal cord injury, broke my neck, blew out my orbit. I was able to, follow my orbital fracture, my recovery to my family, what I was able to see, what I was doing, my physical therapy and rehab with my hands, and how much better I was getting, what the wound looked like. They're obviously in the pain field, there are obviously unique use cases in pain as well. And it's just up to the doctor to be creative. I mean, it's kind of like using Instagram or Snapchat. Whoever uses it just finds a way to use it to their best of their abilities. And we have the results that matter. A lot of my residents and my co-attendings have published on the value of digital health technology and that how it really moves the needle in patient satisfaction scores, as well as the ability to train. I know Kieran has a fellowship. You can record complex cases. The residents love this stuff for reviewing the case ahead of time. And I think that healthcare is an educational business. it's our obligation to educate our patients and their families. And this gives us tools and unique, technologies to create this on the fly in the fraction of time it used to do. You used to have to do this. Not only that, you can upload legacy documents if you have things regarding procedures that you do. You can upload legacy documents very easily to Playback Engage, and so all that legacy stuff you have, that doesn't mean you can't use it. And that's, I think, also real value. We've showed significant improvement in HCAHPS on the inpatient side. And this on the outpatient side, it's the same thing. Your communication improves, the information improves, any transition of care is made better. And even our hospital scores in our department in Lennox are remarkable compared to those who aren't using Playback. And then the time it saves. I mean, these numbers are real numbers. You by not having to write notes or dictate, you can save 10 you can take 10 15 minutes a patient, and it adds up when you're seeing 20 30 patients a day. And it gives you time to be a doctor again. It's made me a physician, and I don't have to worry about typing, looking at the EMR. I just talk, and it takes care of the rest. Here are just some of our big users. Randy D'Amico is one of my partners. Let me see if I can get this to run. It's not working. These are testimonials. We've had numerous guys that have used Playback that are in our department and in orthopedics in particular. And the reviews we've gotten from our big users, everyone loves this stuff. It's just has had huge impact on our ability to deliver care and be a doctor. And I think in pain, especially because patients they're not at their best and they're coming to you, and you can give them something to go home with. And as they get better, they can look back on their highlight reel of their care and keep themselves abreast of all their outcomes. So basically, better communication gives you better care gives better outcomes, and this technology makes it easy. Greg is my partner in this. You can reach out to this QR code with any questions. I know Kieran set aside some time to talk about the use case we have, and Greg and I are more than willing to answer any questions you might have.
Awesome. Thank you so much for that. And so, I can't tell you enough. It's the Engage has been fantastic. So I'm the director of interventional pain at Lenox Hill Hospital, and I run our inpatient, our outpatient, and the fellowship, as you mentioned. And it's been really great to connect patients who are discharged from the hospital and having, kind of a summary of everything that's happened to them and having their care coordinated on the outpatient side. So that's been really great. And then I also use, I'm using the AI scribing as well. It's fantastic. I particularly like it when I'm on the telemedicines as well. So not just using it when I'm in the office, but also so I can just focus on talking to the patients. And it's very, it's a very great system. I've used other systems in the past, and I found that sometimes, what it creates is not as high quality, but I've been very satisfied with the quality of the notes. So, I think the questions that I'd love to take some from those individuals who are joining us tonight. So if you have any questions, please put them in the chat. But my biggest question to you is kind of like where to start, right? Because it can be overwhelming, right? So you're a practitioner who has never embarked in using Engage. Where would you say would be the highest yield, best place to dip your toe in the water?
I honestly think this evening is record the conversation and give it to the patient. That's super easy to do. It's hitting a button. If you want to do screen captures and go over films, it's equivalently easy. But it's just, it just depends what your workflow is. And people who are like, look, you guys see like 50 patients a day. So it's kind of like, this is not like Epic where you have to use it and you can't get by without it. So you have to put the effort in, and if the effort's too high, if the friction's too high, it just, you don't want to slow down, and that's your business. But I think as long as you have decent integration and you can open up your patient on the fly, which Playback and gets it up in your office, instead of hitting a button for the conversation, this is what the plan is. And then the patient leaves with an audio document that they can go home and listen to again and talk to their family. That's really low brow. Next level probably is doing a screen capture, reviewing an MRI, CAT scan, X-ray. super easy to do, but it does require you pull up the film and you're going to, go over it. But on my practice, I'm going over with patients' films all the time. I might as well
Yeah.
record it, and
Yep.
then I get my note out of it. So
Yeah.
that's I think the easiest way to use Engage. And when you add Pro in at the same time, you just get your note, so you can talk to the patient and put out, and you get your note at the same time. So it's 2 for 1.
I think one of the best things is I think we all have patients where we're looking at an MRI with them. We go over the full thing, go over the treatment plan, suggest a treatment plan, and then we're about to end the visit, and the patient's like, can you call my daughter, my sister, my son's sister's mother, and give them a whole recap of everything. And we do it, right, because that's the right thing to do, but it's exhausting. And it's also great to use Engage so that what you have said to the patient is the same exact version that you are saying to the family. And so they could listen to that in the privacy of their home, or they can share it with other family members as well, who may not live, for us in New York City. And I think that's really been valuable as well.
And even I've sent you patients where I send you a video, right? I've seen a patient, and I say I have a patient that has a pain problem that isn't surgical, and I, instead of telling Kieran, oh, go look at this film and cut number 7, you can really see. I just sent her a 2-minute video, and then she knows what I'm thinking. She knows why I don't think it needs surgery, and then she's prepared for the patient, and she looks smarter. And the same thing goes when she sends me a patient. So, I think that the ability to give that kind of conversational information is really valuable for communication, even from doctor to doctor.
Absolutely. That's another aspect that is tremendous, where, I if I send a patient to Dr. Langer to evaluate for structural spine surgery, and he's like, nope, this patient's not a candidate, gives me a quick video, or even sends me the MRI review that he did with the patient. So I know exactly what their conversation was like. It really helps things. I watch that video right before I walk into the exam room, and I see that patient, and I know where to start the conversation. Really enhances, I find, the efficiency of that visit.
Yeah.
Dr. Soin, I see you on there. Tell me, I know you love technology as much as I do, and so I'd love to hear what questions you have for Dr. Langer.
I do.
And Greg.
Yeah. Thank you. Thank you for that introduction. And I just have to say, you can type questions into the chat. I know people actually texted me 2 questions, so I suppose I'll ask them for you. One is regarding workflow. You mentioned something about, this ambient scribe will create a note, but then what? Is there an extra step to actually import it into the EMR? Because I think this physician that asked me the question was concerned that it would actually perhaps cause other than using a template in their EMR, it might actually be more timely to do this ambient scribe note, and then take that note and have to do something to actually pull it into their EMR. So can you just walk us through the workflow on what that's like?
So we have integration into the EMRs. If you're in a enterprise situation, we can integrate. For the purpose of this group, I would imagine it has more to do with in your office, and you may not want an enterprise integration. So the way I do it is, every one of my notes gets automatically emailed to my nurse and my administrative assistant, and they cut and paste it into the EMR. And I'm completely comfortable with the output. I almost stop looking at them, because they're just accurate. And especially the AI trains you too, because when the AI is in the background, you say, okay, here's the plan. We're going to do X dot dot, and the outputs are just structured better than I usually would write it or type it. So in a non-integrated solution, you just talk to it, and then we can forward the note to yourself or to your assistant and automate that, and then it's just cut and paste, copy and paste into the EMR. So you basically run like 2 windows on your machine. You'll have the playback platform on one side, and then your EMR on the other side, and just copy and paste into the note box. That's what I've been doing.
Excellent. Thank you. That's helpful. And I don't think that's going to take that much time at all,
No,
honestly.
it doesn't take any time. It also codes it. You get the code in the ICD.
Yeah.
So if you're coding your own notes, it's fantastic. I mean, it's a recommendation. It doesn't do it for you. In an integrated, it does. But you can get 99% of the value without integration. The cost is really low. When someone had a question about cost, it's not expensive. I mean, it compared to what you spend on all, like transcription or whatever, It's cheaper than that by far. And there's it's just a matter of working into your workflow, and you save so much time. You'd be crazy not to use it. It's just so much better. It's like takes the stress out of your whole day. It's great.
That's awesome. And so the second question that popped up in my text was, what do you have to do informed consent wise to let patients know that there's like an ambient thing listening, and what do you guys do in your practice?
So I've been just say at the beginning, I'm going to be recording our conversation. I record, then the patient say, oh, that's fine. And so I've got an audio recording that. But I think this is a theoretical concern. I mean, a bridge, and there's a bunch of enterprise vendors out there that are selling through Epic and the other EMRs. This is going to be this standard of care in short order. So, and it's a piece of the medical record. The transcription is available, and the note is generated. So the transcription is in the background. In an Epic situation, Epic owns the transcription. You know, if you use playback, you own the transcription. So you have the transcription of the actual conversation, doctor patient, and then you have the generated AI note, that's more structured. And what's amazing is I'll have a conversation. I'll talk about the Yankee game, or oh, I love to play pool in the summer, and I'm a scratch golfer too. None of that gets in none of it gets in the note. It just eliminates all the non-medically related and I screw around with it sometimes. I've done demos of this, and one of my patients who's like one of my neurosurgery partners will start going off on some crazy tangent on purpose, try to screw it up, and it doesn't do it. It just won't take the bait. So it's what's another really wonderful thing about AI.
Hey, David. So I love your presentation. I think it's spot on with, everything that can make our life better as a physician. Now, I did have a great question here. Karen talked about, well, it really helps communicate the information to the patient or to their family. Really great, visit summaries. How does that really work? Like, help me understand that. Is it, just a video summary that's available, or an audio summary, or what's the integration portion of that?
Integration into the EMR or to the patient?
Well, to the patient, right? So how is this information getting actually across to the patient?
Yeah, so if I make a video, I created either on a mobile device on my phone, or more commonly I'm doing it on my computer screen. So as long as you have a computer with a microphone in it, you don't even need a video camera, because I'm not recording myself. I'm recording the screen, whatever I'm showing on the screen. So I either do a video of the screen recording, or I'm doing an audio file, and then that video gets delivered directly to the patient through a text or to the app. They can download the app and get all the content in their app, or as long as you just need the patient's mobile number, and we take at intake and register the patient, and the patient gets it direct to their mobile device, either an audio or a video by text.
So if I'm understanding you correctly, every time you do that visit summary, you have to actually go in and create, correct? Like, you actually have to go and either record or have an audio file or a video file, and that eventually gets delivered to the patient.
It's just the office visit, so if they come in.
And then what are your thoughts on potentially using things like physician avatars to do a lot of that legwork, right? So the end delivery mechanism would be your talking head as an avatar, essentially. Like ASIPP's done a lot of great work, along with many other societies out there, to really change the patient experience. What are your thoughts on that type of engagement?
I'm actually working with Agentic on. I send patients Agentic podcasts, but it's not my voice. We could do that. We thought about avatar stuff. I personally think that getting used to AI and getting used to Agentic AI, which is incredible, but I don't think I want patients to know that it's not me. I want patients to know this is an AI generated thing. It's like you're okay with it now. I think if you try to cover it up too much and make it appear like it's too human, that's when it gets a little weird. And I think patients prefer, you tell them they don't mind it. It's just you're not trying to hide it and say this is, and it's almost like you're just pulling the cover off, and you're saying it's really a robot, but it's a really good robot, as opposed to I'm not really a robot, but and I don't think we should. I think that's the differentiator. I think there is technology now that can sound just like me. I would prefer not to do that, at least for now. I don't think we're really ready. I don't think that's good. I struggle with that. But I don't know what the right answer is. It's so brand new.
I think one of the biggest things I've seen with Engage is that I don't feel like it's making more work for me. I feel like it's capturing just that real, authentic interaction that I'm having with the patient or any interaction I wanted to have with the referring physician, and it's not making more work. And I think sometimes we think that, integrating these types of solutions into our care makes more work. And then I think, sometimes the avatar in certain situations, I feel like that's something that can be used. But also like, just sending a patient a quick video like, hey, your surgery went great. We just finished, just closing up. Very excited to see what your outcome is. Things like that really also adds that
Goes a long way.
humanism, back into medicine that, because of all the time constraints, we often don't have. And I think I've really liked that. And I know the patient feedback has been great about that, like that really humanistic touch, feeling like my doctor really cares. This is personalized medicine in a world where obviously, we're being incentivized more and more to not deliver personalized care.
Yeah, I mean, I think that one of the basic drives of this is using technology for the right purposes. I mean, tech's always pulled us away from the patients. It's forced us to code and do EMR and take courses of how to, essentially what's billing and scheduling and just medical legal protection. And now we're using technology for a positive way. And I agree with you. This is really personalized medicine. Take the DNA crap out of it. This is really personalized. It's your problem in an audio, in a video, your films, not some model. And I think the patients really appreciate that. And it's just so remarkable. It's like, it's amazing it hasn't been done, but it's right here.
I'm going to ask if there's how can people who are on this webinar engage with Engage and Playback?
Greg, I'll let you take it over from there. We're available. We have great customer support, and I would encourage you to try. I think you'll be amazed at how much it makes your life better. And I'll just turn it over to Greg. I have a hard stop at 7, so I'll turn the rest over to Greg. With any questions you guys might have about that, I think he can give you all the information he needs.
Wonderful. Thank you so
Right.
much for
Thanks
joining
for
us
having us.
tonight.
Okay.
Wonderful. Take care.
Bye.
Sure, I'm happy to take that. The process to we've made both of these applications very easy to download from the Apple Store, so you can, or the Google Store, so you can download it for yourself and you can use it and you can try it. We do have a whole solutions team that onboards clinicians bespokely to understand how either Engage or Pro works. We create personalized templates for you. We find out that not only do different service lines have different needs as far as templating, but each doctor or nurse may have a very particular type of note that they need done. But I saw some questions about some of the smaller care facilities that may have unique needs. That's kind of our sweet spot. We have about 600 different templates in our library that people can use for documentation. Engage is to use Engage. We feel it's best as a integrated solution, because you can have your patients present to you and then you can select your patients and you can do whatever from there. So that is a more of an integrated effort, but it's not hard to get up and running on it. It's just it's something that I would connect anybody that wants to know with our solutions team to figure out a way forward. We've done this many times.
Well, wonderful. Thank you so much for joining us. And if anybody has any other questions, we can certainly connect you with either Dr. Langer or Greg and make sure that those questions are answered. And with that, I'll turn it over to Dr. Badwani with our second guest. Thank you.
All right, good evening, guys. And so far, it's been a wonderful presentation. I'm really excited to introduce my friend, John Bowman with SureMed Compliance. He really understands, really we're at the forefront of something incredible with integration of artificial intelligence and how it can actually better help our patients, especially with the way we're prescribing medications. Often it's been hard to track some of these medications. And beyond that, just, as we become more integrated with advanced technologies and advanced procedures, this platform has really shown to help, improve that engagement with the electronic medical record. So with no further things to add here, John, I'm going to hand that over to you. Thank you.
Yeah, great. Thank you, Dr. Budwani. Appreciate that intro. I'm going to share my screen. I'm only going to show a few slides here, but I think one of the ways that we're, I would say, uniquely different in the healthcare space is that we focus primarily on the medico-legal aspects of prescribing. And so we often talk about access to care and the challenges and how can AI help with access to care. That's a broad topic. But if you think about it in terms of what software really is, it is a number of inputs, there's synthesis, and then there's output. And so when you think about access to care, what you're really thinking about are what are the hurdles, what are the roadblocks, what are the things that prevent patients from getting the care that they deserve or that they need? And then you work backwards from that problem. And I think in the beginning, AI was really good at synthesis. I think if you thought of the equation of software, we thought of AI in that synthesis zone or that region there. Really, AI is actually incredible at all three pieces of this now. And so it's a very interesting time to be a software startup or a software company. It's interesting to be in healthcare now because there's just so many problems, I think, that are exponentially being solved because of AI. So if we think about our use case here for what we do at SureMed Compliance, we're really interested in making sure that physicians mitigate their medico-legal, their criminal, civil, and regulatory risk when they prescribe controlled substances. And in interventional pain and in pain settings across the country, we know that opioids and other controlled substances are still an option. They're still needed. And we want to make sure that physicians and licensed healthcare providers can make those decisions so that patients don't end up having to get healthcare delivered by friends, family, and sometimes on the streets. And we know that's the reason for the overdose epidemic is really primarily because of illegally manufactured fentanyl as a direct result of access to care, the lack of access to care. So just a couple of ways that we use this AI in our platform. And one is to review case law to determine the evolving risk landscape with prescribing controlled substances. And so I'll get into sort of a little bit about the history here, and it's super important to see this to understand why we exist and how AI can help physicians when they're prescribing. So what you're looking at here is Title 21 of the Code of Federal Regulations. Most people are familiar with both of these phrases that are highlighted: legitimate medical purpose and usual course of professional practice. Now, the second phrase actually comes from the Controlled Substance Act of 1970. It is a very binary standard, very easy to define, and not something that most healthcare providers worry about. It's a legal distribution or selling of these controlled substances, right? The second phrase, though, is the challenging one. And this is where the landscape has evolved. Even as much as about 2 months ago, we've seen some landmark decisions being made by circuit courts that affect the liability of physicians when they prescribe controlled substances. So that second phrase, legitimate medical purpose, really didn't even come into play too much until the late 90s, early 2000s, when physicians were doing physician-assisted suicide, and we saw a spike in that. DOJ got involved and said that they are not prescribing those medications for a legitimate medical purpose. If you wrap your head around that for a minute, we hear there's a law enforcement agency telling physicians what legitimate medicine means. And actually, when we talk to most doctors and we say, "Are you prescribing for a legitimate medical purpose?" they kind of look at us funny, like, wait, that's up to me, right? Of course I'm doing it. It's legitimate, and I'm a doctor, and it's in medical practice. And what we often have to uncover and share with them is that this is an actual regulatory standard that's been well defined now. And so what does it look like? Well, in order to meet legitimate medical purpose in all 50 states now, a physician who prescribes any controlled substances have to now determine and document up to 26 individual categories of data. And that has everything to do with the way the states define this definition in 2016. Even after Oregon v. Gonzalez, the Supreme Court ruling that basically said the DOJ is not allowed to invoke or define that standard, we saw the DOJ, the DEA completely ignore that, continue to invoke it against physicians. And again, it was finally formally defined by most state boards in 2016. This is an infeasible standard. There's no way for a physician to meet this. And so how can AI help with a product like SureMed Compliance? What we did is we set out to we know the deck was stacked against doctors based on the way this was defined. We knew that civil litigators, criminal prosecutors, as well as state boards, licensing boards, all know exactly what this means and exactly what the matrix looks like. And actually, just to give you a little bit more insight into what it means, if the charts are ever pulled by any kind of regulator or law enforcement agency, or even by an attorney, a litigator, they're going to look at 4 things. They're going to look at the data point. They're going to say, did the physician determine and document the category of data? And again, there's up to 26 of those depending on the case or depending on the patient. Did they use the acceptable method of assessment when they assessed or determined and documented that data point? Did they use the right frequency of assessment? And then what was the outcome? And that comes down to a lot really treatment plan, patient reported outcomes, things like that. Challenging part is this is a moving target because frequency of assessment can change based on outcome for each of these categories of data. And on top of that, there is mountains of case law that continue to come in cases against physicians, whether it's criminal, civil, or regulatory, meaning that this landscape continues to change. So how do you address that as a medical legal compliance company that is trying to allow physicians to prescribe without having to constantly look over their shoulder and wonder, have they met the standard? And that's where AI comes in. When I first founded this company, I spent about a year and a half studying case law. I am not an attorney. It took me a very long time to even understand the language of case law. I would Google every other word just to find out what it meant. I would lean on friends of mine that were attorneys to try and understand this. But for about a year and a half before I even founded SureMed Compliance, all I did was try and figure out what in the world is going on with physicians getting arrested for prescribing. The case law since then has changed significantly, actually, even at the state board level. So how is it that we can stay on top of all of this? And we think about that synthesis part of that, of the equation of software, right? Input, synthesis, or calculation, output. This is one of the areas where SureMed, I think, is actually leading the charge to make sure that physicians don't ever have to worry about looking over their shoulder if they are trying to practice legitimate medicine and prescribe controlled substances to ease pain and improve quality of life. And that is through the AI models that we are training and reviewing this case law. We are constantly getting these models back to suggest what the actual risk level is, and we are updating our platform accordingly. So that's the synthesis part of that. And it's an important part, again, when it comes to access to care. There is another way that SureMed is actually using it. There's actually several ways, but I think in the interest of time, I'm just going to denote that these two ways that we're actually that are probably the most relevant to what we do. Again, understanding case law in a timely fashion, up to date in real time, really understanding exactly what's going on. I said about 2 months ago, the Eighth Circuit Court of the United States in the Ron versus United States of America basically upheld the CDC Federation of Medical State Board guidelines as the standard for legitimate medical purpose, which is CFR 21 CFR 1306.04. We saw that in their decision. And we understand exactly what that means. I mean, it is no longer relying the DEA, the litigators, civil litigators, and even the state licensing boards to some degree are they're no longer relying on the reasonable prudent physician test. They're no longer relying on precedents being set. They now have quite a bit of firepower to go after physicians, and so we have to stay ahead of that curve. In order to create the platform that we have, which helps physicians meet this standard by simply having a patient go through a brief digital encounter every single month in between office visits to collect and synthesize that data into a date and time stamped legal report that flows directly into the patient's chart. And this is sort of what it looks like right here. So you can see there's a few other pieces of information on here that are not relevant in pain, but into substance use disorder, which is an area that we ventured into in April of this year. But all of this data is really, really important, not only for clinicians to make better prescribing decisions, better, safer treatment decisions for patients, truly understanding the risk-benefit analysis whenever they make any decisions at all with care. But there's some other pieces of data on here as well that's sort of a good segue into the other use case for AI that we're using. So in most of the accounts that we work with, which is most of the large pain groups across the country utilize our software. We've got about 3 million digital patient encounters a year under contract. We are the nationwide leader in digital health and pain when it comes to the services we provide. We do have bidirectional interfaces with most of those EHRs, which means not only can we push data, we can pull data and we can synthesize that data. And one of the areas that we have begun doing that in is when it comes to letters of medical necessity. So if we think about access to care, it isn't just about mitigating risk to providers to make sure that patients can get the care that they need without sort of we all know there's been a cooling effect in pain with physicians prescribing these medications. And again, we're not pro-opioid and we are not anti-opioid. I always tell people it took me 6 years to get a degree in history and religion. I should not be telling anybody what the value or the benefit of opioids are. But what I do want to do is make sure that our organization protects physicians when they decide to make those decisions, right? So, so the other use case though is and when you think about access to care is all of these different procedures, right? If we think about one of the biggest roadblocks to care, it's payers. And we see this all the time. We see whether it's the federal payers or whether it's the private payers restricting care through all kinds of modes, right? Prior authorizations, clawing back money sometimes because something wasn't medically necessary. And so how do we use AI to fix those problems as well? Well, not only do we have just about every single piece of the EHR data that we need through our bidirectional interfaces, but we also have incredible amounts of validated longitudinal data that patients month in and month out self-report. And that's things like the PDI, the Pain Disability Index. We look at location and intensity of pain, the NRS. We look at risk. We have a risk stratification tool on here as well that we look at things like psychiatric comorbid conditions, things like depression and anxiety and PTSD and alcohol use. And, there's just so much side effects. And so because of that, we can take the patient reported outcomes and we can marry that data with electronic health record data, synthesize that, and create very individualized treatment-specific letters of medical necessity that physicians can then sign off on and submit prior to doing any kind of procedures or prescribing even medications and things like that as well. We know there's a huge cooling effect at the pharmacy level as well. The big multi-district litigation suit between the DOJ and the 3 largest pharmacy chains that settled in 2022 not only carried with it a very large fine for those pharmacies and their part of the opioid epidemic, but also 27 pages of injunctive relief. And most people didn't even notice that, and is causing sweeping changes at the pharmacy level. So much so that patients are now being told that medications are out of stock when they're not, because pharmacists just don't have the bandwidth to explain what's really happening. And what's really happening is that the DOJ has appointed monitors to the 3 largest wholesalers. All of the pharmacy chains now are, all of the data is being reported through a clearinghouse that Bamboo Health has stood up. And if a pharmacy gets on a restricted list by a wholesaler, they stay on it for life. And wholesalers are putting them on restricted lists if they do not provide evidence that they are also meeting 21 CFR 1306. So this legitimate medical purpose problem is the scope of it is greater now, because pharmacists also have a corresponding 50% corresponding responsibility for that prescription that they dispense. And so what SureMed's doing here on that front as well is synthesizing data and creating letters, automated letters for each controlled substance that goes out to provide evidence of medical necessity for those pharmacists. And what we know now is most pharmacies in the country are accepting those letters and adding those to the patient's chart. And patients are getting a lot less pushback at the pharmacy when they get those prescriptions sent in. So a lot of different use cases that we're using it for. We have AI bots that are also able to enroll patients over the phone and ask these questions to them in any language that they speak. We've trained those models to not only understand up to 60 languages, but also multiple dialects within each of those languages. And it's helping with patients that have literacy issues, or patients that speak different languages, or even just patients that are not tech savvy and are unable to use the application that we provide. So we really feel like AI has helped on the synthesis side. We are exploring and on the output side, and we're even exploring it now when it comes to how to get better inputs and greater inputs, not just from a medical legal standpoint, but also from a clinical aspect when it comes to talk to and how we interview patients and how we capture that data. That's pretty much my presentation about AI and what we're doing, but I'd love to just turn it over to Dr. Budwani and Dr. Soin to anybody, any questions that people might have.
Hey, John, great presentation. I think what you're doing is so meaningful, especially because, our space has struggled right in the past with the way we provided patients access to medication. And I feel like it's been overregulated to a great extent. Where do you think for us as physicians that are practicing in many different capacities, if we wanted to actually integrate what you offer, what would be the first step to actually making that happen?
Well, I mean, integration with our product is pretty simple. And thank you for the kind words, by the way, Dr. Budwani. It's been a passion project of mine for years. I've got a personal family history with opioid misuse and how it's affected my loved ones, and so this has been one of the passion projects that I've had. So thank you for what you said. Integration's pretty simple. I mean, it's very straightforward. We were actually funded through a National Institutes of Health grant. We've studied this. We've scientifically validated this in a 3-year study with the University of Florida. We can basically put this in the hands of physicians at no cost right now. So, if there's an interest in that, really the next thing would be just understanding what the EHR provider they use. We are in the marketplace with most of the largest ones, groups like Epic and, with like Athena Healthcare, ModMed, eClinical, Allscripts, things like that, and we can turn those integrations on pretty quickly. It's a pretty seamless process. It actually runs in the back of the practice. There's not a whole lot of implementation required other than making sure that patients either receive a text message with a link, so where they can enroll in the program and complete these brief digital encounters in between offices. And then the reports, they're generated, flow directly into the electronic health record in the patient's chart. It's just about reviewing it at the point of care and denoting it in the chart what you gleaned from the insights. And we're even looking into further integrations within Athena, where we can potentially push these scores, these validated measures, right into certain fields rather than just as a static report.
For right now, do you know how many physicians are currently actively utilizing your platform?
I'm sorry, say that one more time.
Do you know how many physicians are currently and actively utilizing your platform, or how many practices you guys are working with?
I think we're somewhere now around under contract right now. We've probably got close to around 500 paying clinics nationwide signed up to use our software. We've got around 3 million digital patient encounters a year currently under contract and growing. I think we're somewhere around 8 to 10% of the total paying market right now that's engaging with it. So we've had to pump the brakes a little bit on just on sort of the sales cycle, just because our bottleneck was implementation. And so that's been our biggest challenge, but probably somewhere around 3 million digital encounters a year and about 500 clinics.
So we have a question in the chat, and that is, can you go over some use cases of where a physician's had to defend himself in front of the medical board and may have used your software and how that worked out?
Yeah, thank you. It's a great question. We've been in business for 10 years. And in 10 years of business, we've probably been subpoenaed at least 25 or 30 times criminally, and we've been subpoenaed also in state board cases. I think what's super important to understand and how these cases operate and what they're looking for, and it's a little different at the criminal side than it is at the state board, obviously, and in the civil side, even though they are all using the same standard. They are very much interested in defensibility is based on not necessarily the treatment decision that the provider made. So this is important. It's a really important distinction here. A lot of people think that they're going to get in trouble because they decided to write a large MME or a large number of opioids and other medications and things like that. You may get on lists that way. You might be in a higher percentile than other doctors because of MME. But we have not seen in any real case law that physicians are getting their hands slapped or in trouble because of simply what they prescribed and the treatment decision they made. What we find is that they say there is no way that a physician could have made an appropriate decision unless they had done a proper risk-benefit analysis. So it's not a matter of, what did you do? It's a matter of, is it defensible based on what data did you look at? And so we've been subpoenaed, like I said, a lot of times. I can tell you that we've had one physician go to federal prison that was using our program, and it had nothing to do with our program at all. It was prescribing outside the course of usual professional practice. It was actually a violation of the Controlled Substance Act, not CFR 21 CFR 1306. I will give you the sort of an anecdotal answer to that question who asked it, which is one of the most prolific DEA special agents for the DEA that ever existed. 23 years. They actually have a Netflix documentary coming out about him. A very, very dear friend of mine as well, and sits on our oversight committee. He said, John, if our team actually, he was responsible for putting 15 physicians in prison in 3 years. His team did that. And to make a case against a physician takes years sometimes. So a very prolific guy, knows exactly what he's looking for in his team. He said, John, and he says this a lot when he speaks on our behalf. He said, if our team ever walked into an office and saw that report sitting in a chart, we're going to turn around and walk out. He just said, there's no way we can make a case against a doctor that's gone to this level of detail to determine and document the exact things that we're looking for. Again, you have to understand there's a blueprint here. People think that there's just sort of this ambiguity and that there's doctors looking at these charts when these things get pulled. It is not. Even at state board level, doctors may spend 5 to 10 minutes with the chart. It is prosecutors and attorneys, and they are following a very explicit, specific matrix that they're looking for. We know exactly what it looks like. And instead of having the doctor have to do the work to determine and document it, we ask the patients to spend 5 to 10 minutes in between each office visit, answering a series of questions in a very intuitive piece of software that knows exactly when to deliver the category of data using the preferred method of assessment, and then even the right frequency of assessment, and it'll actually change based on outcome, the frequency.
That's helpful. You know, I'm actually on the state medical board of Ohio, and I have been for the better part of, I think, 13 years. Prescribing cases come up often, and most of the time when physicians get in trouble, it's due to not following a specific line item in the rule set that's in Ohio. And that's what we can sanction someone for. It's not necessarily the MMEs or whatever, as you mentioned. It's actually not following like a specific check mark that's required in the notes. So in that notion, is your software customizable to various regions that might have specific chronic pain rules that have to follow? Like Ohio might be different in terms of what triggers action than Indiana, for example. And is it customizable if the physician needed it?
That's a great question. Simple answer is yes, to the extent that we are using AI right now to understand all of those differences between the states, because there are certainly some differences there. What we tried to do is build out the most robust sort of platform possible so that it can account. There's a lot of AI and step logic built into it already that can account and learn from the way that the patient is answering questions, the state that they're in, to make sure that it's actually determining and documenting that appropriately. So, and then the second answer to that is we also have another feature within the software that allows physicians to create customizable different questionnaires to check those boxes as well. And it can be done at the clinic level. You can turn that on at the clinic level. Not only can that be used to capture data that's required to substantiate legitimate medical purpose, but you can also use that to create quizzes, candidate quizzes for procedures that you like to do. So if you wanted to do spinal cord stimulator trials, you could easily flag patients based on all kinds of criteria that we pull from the EHR, like ICD-10s, location and intensity of pain, insurance information, and you can add and append little quizzes at the end of this that patients are required to go through, that we can flag them for certain procedures as well.
So John, if I got a text message from one of my friends who just started up a practice about 6 months ago or so, and he's on this webinar tonight. He's trying to figure out if they wanted to actually engage with you all and your team, what would be really the next step to making that happen, and what's the process?
Yeah, next step is just on our website, if you go to suremedcompliance.com, there's a little button on the bottom that says request demo. If you fill that form out, we've got a great customer service team. We operate in all 50 states. Somebody will reach out to you right away. You'll within 24 hours, you'll get a response. Somebody will set up a demo of the software. Our team will demo that with you. We'll learn a little bit about the way your practice is and make sure that it's optimized to fit your practice. There is some small contractual stuff. Again, it's being offered no cost through an NIH grant through the HEAL initiative, so you don't have to pay for it. The only thing that you would have to pay for is any kind of post API ongoing fees that an EHR might charge you. That's all passed through. We don't do anything with that other than just to pass that on. But it's a pretty fairly simple thing to turn on. We do a little bit of a map as well. We want to find out what you're already doing in the clinic, because we don't want redundancies and patients to have to answer the same questions over and over again. So there's a little bit of that we do, but it's fairly straightforward.
So are there any fellowships or hospital systems you're actively working with, or is this mostly for private care physicians or private practice physicians?
We've had some success at the academic level and things like that, but for the most part, I would say 90+% of our customers are individual practices or group practices currently.
John, thank you so much for this presentation. This is really eye-opening and really awesome. And I cannot wait to share this with, the leadership at my health system and see if this is something that we can incorporate in our interventional pain offices across across the many states. So really thank you for this. And I look forward to that webinar. The Netflix documentary that you're referring to. That sounds really exciting and interesting. My question to you is, tell me about like the patient's experience with it. Like, sometimes patients get survey fatigue, right? Questions. And then sometimes patients are like, why do I have to do this? And they complain and they don't. So tell me, like, what is that on the patient end? Like, what does that look like? Like, how is that normally structured so that it prevents either the fatigue or it encourages them to follow through and answer all the questions?
It's a great question. I will tell you, it's probably the one that we get the most from the offices that care the most, that are compassionate about their patients, right? I mean, and I think we used to say that the reason patients do this is because they're required to. It's a condition of treatment. We always said that the greatest hook of all time is a physician telling a patient they had to do it. And whenever we thought about our value chain and making sure there's plenty of value within that chain for each segment of it, patients typically, unfortunately, this is just completely transparent, they came last, and it was because we didn't know how to make this user friendly. We didn't know how to just, a lot of patients don't want. There's exhaustion, there's fatigue with tech right now in healthcare. I think one of the big groups we work with, I just found out that they said that there are 64 individual vendors that at some point touch the patient within the process. 64 vendors. And they were like, and it's a big group, and they were like, we have to cut that down to like 3. And so there's just, when technology came out, there was this big push for all these different tech things, and they were all siloed. And then all of a sudden, what we're seeing with AI is you can actually have 1 or 2 things that can do most of the stuff and run as a pair of technology integrated with the electronic health record. So one of the ways we're trying to make this easier for patients, I will tell you, just Dr. Patel, in all honesty, we have patients that do not want to do any extra work at all, and there's just not a lot we can do about that. What we have learned is that if it's explained to them the right way, and I'll tell you what it sounds like, it just sounds like this. We're going to need you to just spend about 5 to 10 extra minutes every month in between visits to just give us a little bit of extra information. It's going to help us make the best diagnosis and treatment decisions. It's also going to help keep us compliant. I'm so grateful for your willingness to do this and spend a little extra time to help us. We have not found most patients that are, there's a fear and stigma in the industry already. And I think patients are fearful of what happens if they have to go somewhere else and go to another pain doctor when they've already been established somewhere. So they're usually willing to help if it's explained the right way. And the other thing we've done is we've eliminated as many roadblocks to them getting it done as possible. We first started out, we had a web version and an app. We now have a web version, an app, a texting platform, and we have an AI hotline they can call in if they can't even do any of those. And so, and we have a help desk that's available Monday through Friday that can answer any of their questions. And we hire, our help desk is US based, and it's hired on compassion. I always tell people we can find plenty of people to do the tech side, and we have them on our team as well. But our help desk is people that are compassionate. That's why we hire them. We train them on how to have those conversations. We know that pain is a very unique patient population. And we want to make sure that they feel accepted, that they feel supported in when they call us and they deal with anybody on our team.
I could also see the transparency of putting this into an opioid or controlled substance agreement that most of us have, all of us should really have our patients sign when we embark in that type of care. Is that something that you've seen your doctors do as well?
Yeah, most clinics, that's actually one of the first things they do is included in the controlled substance agreement that the patients will participate in the program in order to be treated. And it's about treatment. It's not about withholding medication. It's about treatment, right? At the end of the day, in order for the physician to make the best diagnosis and treatment decision, which may or may not include controlled substance therapy, there's data that they need. And this is good, important clinical data. It just so happens that this clinical data has a very strong correlation with medical legal data points required to meet 21 CFR.
Wonderful. Thank you so much.
Thank you, Dr.
Hello,
Patel.
everybody. Everyone that attended tonight, thank you so much for joining us. Our next webinar is coming up on November 11th, and it's going to be a really exciting webinar because we're talking about remote patient monitoring. There's a lot of changes coming up in this space, and there's going to be a lot of opportunities for us to actually provide care outside the 4 walls of our care system. And in doing so, I think we're going to actually improve outcomes. So we'll look forward to seeing you guys in about a month's time. Thank you guys for joining us tonight.
Yeah, and Dr. Badwani, I'm just going to put my cell phone in here as well. We had a few people asking for that or wanting to.
Okay.
I'll just announce it real quick. You feel free to, anybody that's a clinician on here that's interested, I have no problem taking a call. And even if you have questions about any medical legal stuff, we've got a whole team of experts that can help you without charging you any attorney fees or billable hours. My cell phone is area code 941-920-1569. Also, we'll be down at the Business of Pain in Miami this week and would love to connect with anybody that'll be there. Thanks so much, Dr. Badwani. To everybody at ASIPP, Dr. Manchikanti, Dr. Patel, it's an honor and a privilege to be on the same webinar as you as well, and you as well, Dr. Soin. Appreciate that.
Good night, everyone.
Take
Bye.
care.